You know how it starts. It's often something so simple, so everyday. An older person, maybe your parent or grandparent, trips on a rug, misses a step, and takes a fall. It seems almost minor, but that one moment can trigger a devastating injury, one that kicks off a whole cascade of life-threatening problems. We're talking about an intratrochanteric fracture. It's one of the most common and most serious injuries in the elderly.
So what's the big deal? Why is this one type of fall so incredibly dangerous? I mean, it's not just about a broken bone. It's about what that broken bone really means. A sudden, total loss of mobility that can literally be a turning point in an older person's life. We're going to break down exactly why.
All right, so first things first, let's get really specific about the injury itself, because this isn't just any old hip fracture. The official name is an intertrochanteric fracture, and the name actually tells you exactly where it is. Inter means between, and the trochanters are these two bony bumps right at the top of your femur, your thigh bone. This is the classic textbook injury for elderly patients, especially those with osteoporosis, because their bones are weaker and just more likely to break from a simple fall. Now, what makes this fracture so unique is its location. See, it happens outside the main hip joint capsule. And that's actually good news, because it means the blood supply to the head of the femur is usually okay. But the real danger here isn't the bone's blood supply. The problem is that all these powerful muscles attached to that area start pulling the broken pieces apart, making it completely impossible to walk. And if a patient can't get up and move, they're at a huge risk for deadly complications like blood clots and pneumonia. So you can see why getting this fixed, and fixed well, is an absolute race against time. Okay, so imagine this. The patient arrives at the emergency room. How did doctors confirm what they're already suspecting? Well, it all starts with a physical exam. Right away, there are some classic, almost textbook signs a doctor's looking for. The patient is obviously in a lot of pain, and there's no way they can stand on that leg. But then you'll often see this classic picture. The injured leg actually looks shorter than the other one, and it's twisted or rotated outwards. This happens because those strong hip muscles are just pulling that broken femur into that specific position. The physical exam gives them a pretty good idea. But to know for sure, and more importantly, to plan the treatment, they need to see what's going on inside. And on that x-ray, doctors aren't just looking for a line on a screen to confirm the break. They're trying to figure out its personality. Is it a simple, clean break, or is it shattered into a bunch of pieces, what they call comminution? And most importantly, they are looking really closely at the inner wall of the bone, the medial cortex, because that one little detail tells them everything they need to know about how stable this fracture is. And that right there brings us to the single most important question in this whole process, the one that's going to dictate the entire surgical plan. Is this fracture stable or is it unstable? Think of it like this. That inner wall of the bone, the medial cortex, it's like the cornerstone of a building. If that wall is solid and intact, the whole structure can support weight. But if it's crumbled or broken into pieces, the whole thing is unstable and it's just going to collapse under pressure. This one factor is the key to everything that comes next. So to make this official, doctors use a system that's basically a surgical roadmap. It's called the AO/OTA classification. It's pretty straightforward. An A1 fracture is simple and it's considered stable. But A2 and A3 fractures, those are the unstable ones. That's either because that all-important medial cortex is broken or because the angle of the fracture line itself creates instability. And this isn't just some academic exercise. This classification directly tells the surgeon which tools they're going to need for the job. Which, of course, brings us to the operating room. Once that fracture is classified, the team can move forward and get to work on the repair. And listen, there is one single goal that trumps everything else. It's not just about healing the bone. It's about getting a fix that is so stable, so secure, that the patient can get out of bed and start moving, ideally the very next day. This is how we prevent those life-threatening complications we talked about. So how do they actually do it? Well, surgeons basically have two main tools in their toolbox for this job. For those stable A1 fractures, the go-to is often what's called a dynamic hip screw, or a DHS. It's a plate with a big screw that sits on the outside of the bone. But for those tricky, unstable A2 and A3 fractures, the better tool is an intramedullary nail. This is a rod that goes down the hollow center inside the bone, acting like an internal splint. It's just stronger and way better at sharing the load, which is exactly what you need for an unstable break. So the surgery is a success. The bone is fixed. But the journey is far from over. Now comes the really hard work of recovery. And that path back to getting around starts almost immediately. I mean, we're talking physical therapy often starts the day after the operation. Of course, this goes hand in hand with managing their pain, using medication to prevent those dangerous blood clots, and taking regular follow-up x-rays just to make sure everything's healing up nicely. The theme, again, is safe, early movement.
But even with a perfect surgery and the best rehab team in the world, the road to recovery can have some pretty serious bumps.
On the mechanical side, you can have issues with the implant itself. The one they really worry about is something called cutout. That's where the main screw literally cuts its way out of the soft, weak bone of the femoral head. Besides that, the bone can heal crooked, or sometimes it just fails to heal together at all.
But honestly, just as dangerous are the medical complications. And take a look at this list. Does it sound familiar? Blood clots, pneumonia, infection. These are the exact same life-threatening problems of being stuck in bed that the entire treatment, the surgery, the rehab, was designed to prevent in the first place. It just goes to show you why every single step along the way is so critical. So when you boil it all down, the entire philosophy for treating this fracture can be summed up with this one simple mantra. First, you line up the bone pieces as perfectly as you can, that's anatomical reduction. Second, you lock them in place with a strong implant, that's stable fixation. And third, you use that stability to get the patient up and moving right away, that's early mobilization. You know, for generations, an injury like this was often a final, devastating chapter in an elderly person's life. But what we've seen here, and what's so incredible, is that with a deep understanding of the forces at play, with precise surgical tools, and with this relentless focus on getting people moving again, modern medicine is truly rewriting that story. It's turning what was once an endpoint into a really challenging, but absolutely manageable step on the road to recovery.